Melissa McConaghy is the Director and Principal Physiotherapist of Advanced Rehab Centre, which is located in Artarmon in Sydney. Melissa is a specialist neurological clinician, educator, author and health entrepreneur. She established Mobile Rehab Innovations in 2006 as an entirely mobile rehab service and Advanced Rehab Centre in 2009 after recognising the need for a purpose-built neurological rehab centre providing expert rehabilitation for people with complex therapy needs in Sydney. She is also founder of PD Warrior, a program for people with Parkinson's that is taught and licensed internationally, and Insight, an online conference that is part of the global education calendar for people with Parkinson's. Melissa sits on the Clinical Advisory Board for Polio Australia and is a current Australian Physiotherapy Association branch councillor. She is past chair of the APA New South Wales Neurological Chapter and past national representative. Melissa has worked in a variety of neurological rehabilitation settings, both here in Australia and overseas for 20 years, and has taught on a range of topics including intensity in stroke, neuroplasticity in Parkinson's, Parkinson's and other movement disorders, introduction to polio, hydrotherapy for neurological populations, and contributed to the production of the APA Level 1 Neurological Rehab course. Melissa is the author of the Amazon best-selling book, The New Parkinson's Treatment Exercise is Medicine. She was awarded the Australian Physiotherapist of the Year in 2019 and received the Australian Physiotherapy Association New South Wales Branch Council Award for contribution to the profession in 2019 as well. Today, Melissa will be talking to us and introducing the LEXO, which is the latest innovation in gait training technology and is particularly relevant for those of us who have a gait issue post-stroke.
Thanks, Michelle. Thank you so much for the warm welcome. Hi, everybody. So I just wanted to put a little context around why I bought such an expensive piece of machinery. And it kind of came down to a couple of different things. We know from the literature that we really need to work hard if we want to improve people's gait. We need to get a lot of stepping practice in. And unfortunately, in most gait rehab settings, we don't achieve really high stepping rates that we need to. So typically in a gait training session, you might achieve about 500 steps in a training session. And that can be with one therapist or three therapists, depending on how much support you require. So that was one of the first issues that we were keen to address. The second one is that the intensity of the rehab is typically quite low level as well. So even though we try and work people quite hard, when we strap a heart rate monitor onto people, we typically find that the heart rate is still quite low. And that's for a number of reasons. One might be medication like beta blockers, for instance, but it also might be that the energy that's consumed to get one foot in front of the other can be really quite high, but also incredibly inefficient. So we can't get the rate of speed and stepping up high enough to actually achieve enough cardiorespiratory training. And the result of that is that we don't get the heart rate up high enough, and that has a serious effect on gait outcomes and what we can achieve in a therapy session. So they were two of the main issues that we sought to address with going down this path of looking at robotic gait trainers. The third one was motivational issues, not something that we typically experience here in our clinic, but I certainly know that if you've been working at your walking for a long period of time, many years, it can be sometimes quite demotivating, especially as there's aging factors that can come into play as well. It can be quite hard to keep at it and keep walking and keep setting new goals, etc. It can be quite labour intensive, and the reason that's a problem is that it can limit the amount of therapy that is delivered. So if we have a client that requires a lot of support, so up to 3 therapists, that can be very expensive for the individual, so that's self-limiting in itself. And the other problem is that it can reduce the amount of time that we could book into a diary. And if you're needing help at home, you might only be able to walk with a carer or somebody with you. And again, that reduces the amount of time that you get on your feet. And so labour intensity does actually impact the amount of training that you actually receive in your gait rehab. Gait training can be quite inefficient and effortful in your walking pattern, particularly if you really struggle to shift your weight over to one side. So it's often that hop along gait that we see in rehab, and that can be reinforced quite a lot if there's not very strict frameworks put in around how that gait rehab is actually achieved. And that's not just so that it looks normal or pretty. There's actually efficiencies to be gained by having a symmetrical walking pattern. And, you know, just reinforcing that inefficient gait pattern can actually require much more energy over time. And that's definitely a problem that we experience. Even with treadmill training, we just often really struggle to get more symmetry of gait. So that's definitely something we'll need to address. For those of you with biomechanical joint pain, stresses, obviously weight bearing can be quite painful and uncomfortable, particularly if you've got degenerative problems with osteoarthritis or you've got an injury hanging over from the past, etc. So we we've been exploring body weight support harnessing over treadmill for a long time, and there's definite merit in that. So we wanted to explore ways to enhance that. And then other training limitations, particularly if people have cognitive issues or behavioural issues. We deal a lot with people with brain injury and behavioural concerns, and particularly if you've got a fear of falling, that can trigger quite profound behaviour concerns and outbursts, which again become quite self-limiting in training. So I just wanted to put this slide up to give you a little bit of context around why we started to explore robotic gait trainers. Some of the literature, because I think it's always good to start from the evidence base. So we looked at some of the literature, and one of the articles that I remember back in 2011, it was a lovely piece of work that was published by Hornby and colleagues, actually looked at dosage, and they looked at what happened if you had somebody on a treadmill doing 4,000 steps in a gait training session versus a regular training session where they were doing under 1,000 in this scenario, and in our case, we typically achieve around 500 steps. So they looked at what was the knock-on effect of doing much, much higher dose in rehab versus significantly lower but more traditional volumes of rehab, and what that meant in terms of real-world change. And so that's demonstrated here. And if you look over here in this graph, you can see a very marked difference between the group that did 4,000 steps in rehab. They actually achieved significant amounts of physical activity in their real world and their everyday activities, versus the group who virtually had no change in physical activity levels, continuing on doing their 500 to 1,000 steps in rehab. So this was one of the first studies that pricked up my interest, because it suddenly said, well, dosage is really important. And then we've got quite a clear linear relationship over here between dosage of number of steps conducted in rehab versus what actually happens to physical activity levels, so that we know dosage is really important. So we need to get the number of steps per session up much, much higher. And then because of what we know about neuroplasticity, so the brain's natural ability to rewire itself and become more efficient, we know that we need to conduct those rehab sessions very frequently, whether they're actually in a physical rehab centre or they're done under a prescribed exercise program at home. It doesn't really matter as long as we're getting the step dosage up specifically for this reason. And then when I talked about intensity before and why it mattered, this was another study that the same group of people actually conducted 2019, and they actually had 3 different groups, and they had a high variable group. So this was a group that worked at a very high cardiovascular intensity, so about 65% and above of their heart rate max. So that's quite a high level. You know you are definitely working quite hard when you're working at that level. And they were doing a range and a variety of lots of different tasks. So they were walking on treadmills, they were doing obstacle courses up and down slopes and stairs and things like that. And that's the purple group here. And then they had another group that just did high intensity training on a treadmill. So again, they got their heart rate up above 65% of their heart rate max, but they were just walking forward on a treadmill. And if I orientate you here to the graph, you can see that self-selected velocity, so their comfortable walking speed, improved significantly from baseline to the end of the intervention in the 2 groups that had their intensity level up much higher, over 65% of their heart rate max for training, which was relatively well sustained, I'd have to say, for a 3-month follow-up period, versus the group who were doing variable training. So again, they were doing treadmill training, slopes, stairs, obstacle courses, but there was much, much less focus on getting their heart rate up about over 65% of their heart rate max. So they weren't working hard at all, and they probably could carry on a conversation quite comfortably. And you can see here a remarkable difference between the blue line here and the other two lines here, and the main difference was around cardiovascular intensity. So it's this study and others quite similar to this that really started to drum home the impact of intensity in training. So yes, you do need to be working hard in order for you to achieve a consistent outcome. And we know from our own clinical experience when we put heart rate monitors on our clients, it's really hard to get the intensity rate up high enough in our typical traditional rehab setting. So again, this was like, okay, well, we know what we need to do from the literature. How do we go about doing that? So here are just a couple of case studies just to kind of give you a flavour of who we see in our clinic. So this gentleman here, in his normal physio session, he achieved 633 steps, and we actually physically counted every single one with a cattle counter. And he spent just over a minute, so rounded it down, in that 65% and above heart rate training zone, which was not enough at all, and that's in his typical training session. So this was just getting a baseline for us and doing our own audit. This is a lady on a treadmill, walking at 140 steps per minute, and you can see here a very unsymmetrical, inefficient gait pattern, and she's in a bodyweight support harness for safety, but also so that we can put her heart rate up. But because of the number of rests she requires, she spent zero amount of time in that training heart rate zone. This gentleman over here, he did actually quite well in his steps, in his typical gait rehab session, and he conducted 710 steps, and he had about 10 minutes in a sufficient training zone. And we know from the literature you need about a minimum of 12 minutes to actually achieve a training effect on your cardiovascular system. So he's getting close, but he's not quite there. And then this gentleman over here, he did really well in his gait training session, and he did 2,231 steps and just on the threshold for achieving a cardiovascular training session. So I just wanted to put this up to give you an idea of who we've got in our clinic and what they're actually doing at the moment. Got a very noisy motorbike out there, sorry. All right, so how do we improve walking outcomes? We know what the literature tells us. We know what we're doing in the clinic. We use bodyweight support treadmill training routinely, and we love it and we think it's fantastic, but there are still limitations. It's very labour intensive. There's not a lot of feedback to you, the individual, about what's going on at the feet. And we're either holding you up and trying to look at what's happening with your weight distribution, or we're down at your feet trying to get a symmetrical gait pattern. So putting it all together is typically really hard for a clinician. We know the heart rates are usually quite low, so we're not achieving a lot of time in the heart rate zone that we need to either. So bodyweight support treadmill training is fabulous, but it's certainly not the be-all and end-all. There's lots of limitations with that. So the only real alternative really is to explore robotics, and that's what started us on the journey. I won't go into the two different types too much, but just safe to say there's two different types of robotic gait trainers out there at the moment. One is an exoskeleton that's used typically as an assistive device. So this is used a lot in spinal cord rehab, where it's basically put on an individual like an external skeleton. Essentially, they stand up with bilateral crutches. Somebody might help them to walk, and then they might walk across a designated area, mainly to experience walking. It's not fast enough to be a functional walker at the moment, but it's a very interesting space that will continue to evolve. But I don't think we're there yet, and I don't think, because we can't get the gait speeds up high enough, we can't get the stepping dosage, and we can't get the intensity that's required or what the literature is showing us. So we discounted that. We didn't really want to go down that pathway yet. So we looked at the other type of exoskeleton, which is a static version. So that's essentially something that stays in a rehab or exercise environment. It doesn't travel anywhere. Clients come to it and they do their gait rehab on that device, and that's essentially what we explored, and that's how we ended up with the LEXO and started looking at the literature around that. So there are, when we get down to the static devices of exoskeleton, there are also two different styles, two different ways that the mechanics are designed. You might have heard of the Locomat. So there's, I think there's two devices down in South Australia, two Locomats. There's been a lot of literature written around the Locomats. They're very, very, very highly priced, around $1 million. And unfortunately, the literature really doesn't support their use in terms of increasing independence in walking, walking distance or walking speed, which are all very crucial components if you want to improve your walking outcomes. And this actually comes from a Cochrane review. So if you look at literature, you typically get randomized controlled trials, which are clinical trials of one treatment versus a control to see what's improved from the intervention. And then in a Cochrane review, you might also have some case studies or something, and it's all compiled together. And it's typically the highest level of evidence you can get because it's a summary of all the pooled data that you could possibly get that fits the criteria. And it's very rare because of that you get any outcomes from a Cochrane review that doesn't require further information. And in this case, surprisingly, it said that body weight support treadmill training and robotic exoskeletons did not improve the chance of gait independence compared with conventional physical therapy. Now, the exoskeleton that they're talking about is that Lokomat version. So that is basically something that articulates with the hip and the knee. So there's not a lot of variation required, but it will give you a symmetrical gait pattern. You can get the dosage up, but you don't have any intensity because the machine is basically doing most of the work for you. So that showed that it didn't improve gait independence and nor in the body weight support treadmill training, which doesn't surprise me given the experience we've had with body weight support treadmill training. What I found most interesting was that the use of the robotic end effector, which is the LEXO and the device that we've actually purchased gait trainers in rehab for people after stroke, did increase the chance of gait independence at the end of the intervention phase. So for me, that's fantastic because it takes a whole cohort of people at the moment that are very labour intensive. So think about the people that are not walking independently at the moment, require 1 to 3 people to assist them, can only walk short distances with or without aids. That's a whole cohort of people that are self-limited in their ability to walk for all those various reasons and don't typically achieve functional walking. That is a group that we now can start to really target and help with devices like this end effector. So it not only improved independence, it was also very specifically effective for people within 3 months post-stroke and for those that couldn't walk, so the non-ambulatory population. So that was really interesting, and that's from one of the highest sources of evidence you can find. And then not only did it improve gait independence, but there was a system RCT that was also pulled out from 2019 showing that it also improved gait velocity and maximum walking distance. Now, if you want to improve your walking, independence, gait velocity and maximum walking distance are absolutely crucial, and this has shown that the robotic end effector device like the LEXO is much better at doing that than traditional physiotherapy or bodyweight support treadmill training. So I was pretty much sold from the literature. It's very compelling and very strong literature. So this inspired me enough to fly over to Austria to have a look at the first prototype that they developed. And having looked at that study, looking at how patients performed on the device, their feasibility and acceptability of the device and what they were planning to improve on as well was enough to convince me that this was the way to go. And so I purchased the first one in the world. And then we had that installed in September of last year. Just a quick summary of exoskeleton versus end effector. So the exoskeleton is the Lokomat, and the end effector is the LEXO. And again, just in terms of improving gait velocity, just I guess to reinforce what I was saying is the gait exoskeleton here doesn't improve gait velocity and it doesn't improve walking distance, whereas the gait end effector, when you look at the pooled data, has a very compelling statistical outcome to show and prove basically that the end effector style of gait training can improve both gait velocity and walking distance. I wanted to show you this here as well because the body weight support treadmill training actually, although it doesn't conclusively say that, and I'll just only because this line crosses this big fat line here in the middle, it has a trend towards improving gait velocity and gait and walking distance, which is why we use the body weight support treadmill trainer in the absence of any other robotic device prior to getting the LEXO. So I guess pulling all that together, looking at the literature, pulling from our own clinical experience, doing an audit of what our patients were doing in the clinical setting in terms of step number and dosage, and then flying over to Austria, it was by far the best outcome, I thought, for our patient group. So this is the assistive device that I was telling you about. This is the Lokomat. And then this is the LEXO, and that seemed to be by far the most, I guess, the best decision if we wanted to help improve people's walking outcomes to go with the LEXO. So let me tell you a little bit about the LEXO. So this is what it looks like. It's an enormous device. It takes up, about 15 square metres of foot space. You can access the device from a seated position, so either from a chair or a walking wheelchair position next to the device. And then you can either be hoisted up and onto the machine, particularly if you are unable to step up yourself, or you can move these orange bars out of the way and you could actually literally just step into the device. You wear a harness and that's attached to the top of the machine, so that's what's used to support your body weight and to hoist you in and out of the machine. And then you've got the computer software, which gives you feedback about what's happening down at your feet. So you can see here your feet are actually strapped into the foot plates, and that's what actually drives the motion. So we can set the cadence, so the speed of your steps. We can set the distance that you actually step out in. And then we can actually change how much feedback we receive for different components to help you improve your walking. So if we want to work specifically on getting your heels down, for whatever reason you may not be getting your heel down on the floor, we can actually change the setting so that you only focus on what's happening when your heel hits the ground at heel strike. Or we might be looking at how much clearance you are getting when you have your foot come through in swing phase. And so we might be specifically looking at what your clearance is like as you go through that part of the swing phase of your walking. We might be looking at how much weight distribution you're achieving yourself. So there's lots of different components, but because we can get that sensory feedback immediately, you get real-time feedback on exactly what's happening down at the feet. We get real-time feedback and we can make adjustments constantly to make sure that you become really efficient in your walking pattern. So it's got two different modes. It's got passive mode and it's got assistive mode. Now, when I looked at the device in Austria, I probably didn't appreciate how powerful that passive mode was, because I thought, why would you want a machine just walking for you? How is that ever going to teach you how to walk? But what we've actually learned through probably 4 months of experience with the LEXO now is it's fantastic, because what the machine does is it actually helps you to achieve a very efficient walking pattern at the right speed with the right weight distribution, the right foot clearance. It gives you the best possible walking outcome for you right at that point of time, and then you work on the different components, either trying to override the machine or reinforce what the machine's doing. And so what happens is you'll do up to 30 minutes on the machine if you can achieve that. Most people take a little bit of time to work up to that. And then you'll do walking training after you've actually done your 30 minutes on the device. And most people come off walking dramatically faster, dramatically further distances, much more efficient with fewer gait variations between left and right foot. So there's a lot more symmetry in the gait. Immediately, because it's retraining an efficient walking pattern for you at the right speed that's appropriate for your height and your leg length, etc. So that's been incredibly powerful. And because the machine's doing all of that and you only focus on one key component as per your therapist's prescription, you can really hone your skills of what you need to, what's most relevant for you in terms of improving your gait. And what we're seeing now is that we're getting really lovely carryover from a 30-minute session. Somebody might have carryover 48, 72 hours after that session where they're walking faster. They can walk further because they're more efficient in their gait. They've got a confidence because they're walking a little bit better, so they're improving their independence. And that's just after a couple of sessions, or after each session they're getting that carryover, and that's just typically building if they're coming in every couple of days. So that's been absolutely amazing for us to observe, and that's the passive mode. And then if we want to, we can unclip that, and then people can go into an active mode where you basically drive all the components yourself. And that's more, I guess, akin to walking on a cross trainer, but you can only walk in a very efficient walking pattern because that's already built into the machine. So it's very powerful. It's been amazing, and we're absolutely loving it based on our 4 months of experience there. So in terms of LEXO benefits, I've talked about dose. So basically we've seen people achieving 4,000 steps on the machine now. So if you think back to what I said originally, people are achieving in a typical rehab session around 500 steps per session. We have quite a range because we've got a lot of different variation in the kind of clients that come here. But we're achieving in most sessions now over 3,000 up to 4,000 steps in a 30-minute session. Most people don't do much beyond 30 minutes because they're absolutely knackered at the end of that. They're working really hard. We know we can get the intensity up because we've got the heart rate monitors on people, and they're spending the majority of their time on the LEXO above that 65% heart rate max. So they're getting fitter, they're building their endurance, and all of these things are going to play into improving their walking outcomes. We can be much more precise in the way that we prescribe things to work on with exercise, because we get instant feedback from the sensors in the foot plates. We know what's going on and we know how to help you, so we can be really precise in what you need to work on and what you need to focus on, which we can't be if we're trying to hold you up just doing an obstacle course or walking over ground, and we certainly can't do it on bodyweight support treadmill training. There's just no ability to get that feedback and that precision. So that's been fantastic. It's incredibly motivating to see those steps building and to see fitness increasing, so that's been fantastic as well. And certainly from an employer's perspective, there's a significantly decreased injury risk for our clinicians, who are often down at the feet, bending over, twisting. That can be very hard work, and therapists can be prone to injury. So we don't like that. And also, if we're holding people up, there's always the risk that somebody could fall in traditional gait rehab. So there's always that risk that could happen, and that instantly gets wiped out because you're supported by a harness. You can't go anywhere. So that's been amazing for us to see. And when you buy something overseas from a prototype, you never know if you're going to get what it says on the box. And I have to say 100% it's been exactly what they said it would be. Some of the considerations: we've not had to turn too many people away from the LEXO. It's incredibly accommodating. But typically, if we have, it's because they haven't been weight bearing recently enough and long enough in a concentrated fashion. So we're more concerned about their lack of bone density, osteoporosis, and the risk of fractures. So for people that haven't been ambulant and haven't been walking for a long period of time, we generally would get a DEXA scan. We'd have a really good look at bone density, and then we'd make an educated decision on whether it was going to be safe, whether the benefits would outweigh the risk of fracture, for instance. If there's really significant contracture, so again, for people that have been wheelchair bound for a really long time, they may not have the ability to stretch out the legs at the hip and the knee well enough, or the ankles. And again, as I said, the machine is incredibly accommodating, but there is a point where it's no longer efficient if we have to really accommodate for one leg being significantly shorter from the other, because we can't stretch the leg out fully. So range of motion is a consideration. Levels of spasticity. So again, we've had patients with incredibly high levels of spasticity. It does tend to improve on the machine, and we've not actually stopped anybody from using the machine. It's certainly not a risk factor. It's just something that we need to monitor and alter the settings to make sure that we can be as accommodating and it can be as comfortable for the individual to train as possible, particularly if that clonus kicks in, when the heel will start jumping around. That can be uncomfortable and disconcerting for patients. So again, it's just trying to set people up so that it's effective gait training for them. If we've got a lot of ataxia, so that's where people have a lot of difficulty controlling their body in space, either the trunk or the limbs. Again, because we've got lots of capacity to really block people into the device at the hip and the chest, the truncal ataxia it's not a problem for us at the moment. It's only when people have difficulty holding their head up that it can be quite a significant problem, but we've not had anybody be unsuitable from that reason at the moment. If people can't follow two-step commands, that's something that we would consider a bigger risk factor, particularly as it is a robotic device. We need to have a certain level of appreciation around the safety of getting people on and off the device. Goals. And we've got two different categories of patients. We've got people that want to improve their walking outcomes, so those that want to improve their independence, their walking speed and their distance. And then we've got the other group who probably aren't going to become functional walkers, as in they don't have walking goals, but they want the experience of being upright. They want to improve their fitness, and they're not getting the opportunity to do so elsewhere. And so we've got quite a few patients that will use the machine specifically to get upright, to experience walking. You get the benefits of that, and it does wonders for the bodily functions, for pain levels, serotonin, and to get the fitness levels up. So we really kind of have two different categories of client at the moment. And there can be other comorbidities. So if there's pressure areas or sensation area, like spinal cord injuries, or you don't have a lot of sensation in the pelvic area there, especially where the harness goes in. If you've got a history of cardiovascular problems, fitness is really low, all of those things sort of factor in basically into what we prescribe and how we start you off on the LEXO. We might just do a trial just to see how you tolerate it, how you enjoy it, if there's going to be benefits, and then we start to build a program around that. We rarely use the LEXO in isolation unless it's for that second group of patient who want to come in and just experience being upright and have fitness goals, but not necessarily walking goals. For the first group who actually do have walking goals, then we will usually bring that person in to use the LEXO as part of a much bigger program where they're doing overground training. They're doing slopes, stairs, sit-to-stand practice, transfer training, all the things that make them functional as walkers. Because I think the LEXO in isolation, as good as the literature is, we know that that needs to then be translated back into what people are doing in an everyday capacity. And so we want to build that independence, that ability to walk in lots of different environments, including slopes, uneven pathways, gutters, all those sorts of things. So we need to train that as well. So we typically have people doing the LEXO as part of a bigger, broader plan. So people might come into the gym 3 times a week for an hour, and they'll do half an hour on the LEXO and then maybe half an hour of overground training. And we would typically have them come in and do that for at least a month. And that's how we're starting to achieve really outstanding improvements in walking outcomes. So I won't yabber on too much. I'm just conscious of time here, but I just wanted to show you 2 different case studies here. So this is a gentleman that had a stroke in November of last year, and he was walking, I showed you before, 710 steps in his normal gait training session, just under the threshold for a cardiovascular training effect. And you can see here there's quite a lot of gait asymmetry. From a physio perspective, this is certainly what I'm looking at. So he's having difficulty getting that left leg through, as you can see there. There's definitely a trip hazard. He's got a wide base on his stick specifically for that reason, not getting a lot of weight over onto the left-hand side. And I would say that's a fairly common hemiplegic gait pattern. Many of you would recognise that. And then I get him on the device, or Sharon's got him on the device here, and what we're starting to see now is the machine is forcing that weight distribution. It's forcing him to take symmetrical gait stepping distance, which is appropriate according to his height and leg length. We can increase the speed, and we're making sure that he's working at a much higher rate, although you can see here, this was in his very first session on the LEXO. He doubled his step count in the first session, so we're talking about dosage here, and then intensity. So tolerated incredibly well, and he's doing very well with his gait rehab now. So that just gives you an idea of what the LEXO looks like. And then this is another lady here who has this very asymmetrical gait pattern. She's wearing an AFO on the left-hand side. Gait speed looking pretty good on the treadmill. But again, there's a lot of things that I would want to work on and improve on, specifically getting weight over onto that left-hand side and trying to even up that symmetry of walking. And I can see here that Catherine's intensity is not sufficient enough. So walking outcomes are going to be hampered because we can't get her training effect, her heart rate up high enough. And in Catherine's first session on the machine, she did 1,200 steps. You can see here she's just figuring out, she's just hanging in the harness at the moment. But once we get her to stand up, and you can see here, I don't know if you can see here, but her heel's not getting on the floor either. She's not getting that heel strike. And now we've asked her to stand up to take some weight, getting that heel down. And then over here we can change the feedback that she gets on the machine to really focus on either getting that heel down or clearing the foot through, making sure she's got even weight distribution, etc. So in terms of dosage, in her very first session on the machine, it was instantly improved dramatically, and she worked really hard for the first time in a long time. And I think with this particular device, you can't run away either. It's very hard to get away if you don't want to work hard. So you can stop and have a little rest, but you can't run away. And I think as a therapist, that's fantastic because we can get people working really hard, and you go home feeling like you've really achieved some significant outcomes. So if we just recap and circle back to what I talked about before, one of the major issues that we experienced in gait training was the low step rate. We've certainly seen that knocked on its head with the LEXO. We've been achieving, as I said, 3,000 to 4,000 steps per session versus the 500 that we took in our baseline audit. In terms of intensity, yep, blown out of the water again. There's heaps of capacity for people to spend more time in their heart rate training zone. If we extrapolate from the data and the research what we know, that will have really significant outcomes in terms of building endurance, building distance that people can travel, and the speed that they can do that in. It's really improved our labour intensity. So we typically just have one person helping a patient on the treadmill, and that's been fantastic because it means that we're using less of somebody's budget or private, out-of-pocket costs, which is fantastic. And that can usually extend the number of sessions that people are achieving in formal rehab. So that's been fantastic for us. Again, you can see inefficient and effortful walking patterns. Because the walking pattern is programmable and it's come from a physiological gait pattern, people are achieving lovely symmetry, lovely cadence, lovely step length that's appropriate for them. And we can program all of that in, make the adjustments, and we're seeing that carried over for, you know, at least 24, if not 72 hours after a single gait training session. It's just reinforcing that lovely walking pattern in a really safe environment. Reduces some of the joint stress and pain because it's got variable body weight support for the individual as they build up their strength and protection mechanisms around the pelvis, the hip, the knee, whatever it might be. And it's taken away most of our safety concerns for sure. So for people that are really concerned about falling over, it's no longer a concern. You're not going to go anywhere. You're safely harnessed into the machine, which means you can divert 100% of your attention to focusing on improving your walking, whatever part of that walking, what component you really need to focus on. So again, you're not distracted by lots of other different things like standing upright and being safe, and neither is the therapist. So that's been an outstanding outcome from all of that. So that's the end of my formal presentation. Hopefully that's given you a good background into what we do in our gait rehab, why we made the decision to upgrade to a robotic gait training device, and why I think that really does provide the gold standard of how somebody can improve their walking outcomes. I think it delivers on everything we sought to achieve in our research. We've been incredibly impressed with the device over the last 4 months, and we just want everybody to come and have access to it. So at the moment we see a lot of clients through NDIS, and we don't charge any surcharge for them to come and use the device. It's just part of their session. As I said, it's typically done as part of the Stand, Walk, Run program. And for people paying out of pocket, you just come and have your normal session with a physiotherapist. We book it into the LEXO. You don't pay a surcharge. So we're hoping to make it as accessible as possible for people that can actually make it in and see their physio. So that's the end of my presentation, and I'm very happy to take any questions if you've got any.
Well, a big thank you, Melissa, for coming on today, love, and running us through that program. It was really an excellent presentation. So thank you very much, Melissa.